Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse, and protectors of the developing brain. Welcome to the Cranial Doc Podcast, where we master the work that actually changes lives. Craniopathy, nervous system-based care, and the business systems that let you scale without selling your soul. I'm Dr. Anthony Pellegrino, pediatric chiropractor, certified craniopath, and proud automation geek. Let's dive in. What's up, subluxation slayers? It's me, Dr. Anthony Pellegrino, the Cranial Doc, and excited for another episode. We're going to take a little bit of another riff episode. I pretend like any of these are just like me planning out a lot of talk ahead of time, but a lot of times the planning is just, wow, this is a really good idea. I do 5 minutes of research just to kind of outline it in my head, and I go from there, and that's what we're going to talk about today. So those of you guys who don't know me that well, or some of you guys who know me well, know that while I am known heavily as a pediatric doctor because of ICPA, PX Docs, Focus Academy, you name the pediatric program, if it has to do with correcting subluxation, I've probably been a part of it. And that's a huge part of my practice and my joy and the reason I wake up in the morning and the whole reason for having this podcast to begin with. But one of my other greatest joys, and actually probably I wouldn't say pediatrics is the highest volume in my practice, but probably the second highest focus in our practice is adults with TMJ disorder. And a lot of the huge, massive increases we've had in our practice is going deep and helping individuals with TMJ. We do really extensive TMJ work through neurologically based chiropractic and craniopathy. But because of that, I see this same exact mechanism show up in my office every single day. And you do too, okay? I hope you realize it, and if not, we're just going to put some words to it. Okay, so let's talk about the average patient that I have coming to my office, either who is complaining of upper neck pain or headaches, and then we ask further questions, and yes, they say that there's a jaw involvement, or they're coming in specifically for TMJ disorder. So they come in, they've got this TMJ disorder, all right? And then so there's men and women, there's both, and the mechanisms are same, but different, okay? So we start having a little bit of a conversation, we go through our consultation, and then whenever I see this, I'm going to start to ask more questions about like, oh, do you notice that you snore at night? I'm going to start, of course, ask questions that have to do with like anxiety or the way that individuals will talk about chronic sympathetic stress. We're going to talk about trauma. We're going to take all of these different pieces like that. So like snoring and mouth breathing, I care about because of airway. We're going to talk about sympathetic stress as well. And then we're going to kind of just go through and get an overall big picture of like what's going on. Is there clenching? Is there grinding? Everything else like that, right? So we do our normal consult. We just like to have issues be informed. I'm expecting typically patient will tell me when they come up with these challenges, there's usually some kind of mental health component just because the TMJ is not only so massively painful, but because of all of the like direct ties into the nervous system and the sympathetic response in that area. And what we'll also expect to see is some kind of like grinding. We'll expect to see some kind of like snoring, which is sleep issues. We'll expect to see, or oftentimes we'll see like sinus challenges. And when I'm starting to see more and more and more things that line up, I'm really starting to think, okay, this isn't just a jaw problem. This is a whole systemic cranial issue, right? What I like to tell patients all the time, and especially coming in with TMJ disorders, and especially someone who's referred from a dentist, our number one referral sources of every patient in our office is a few different dentists that understand what we do and refer to us. And the funny thing is that I have one oral surgeon who refers to us all the time when he is just like, if he has a case and he's like, I don't know what to do with it, he sends it to us. And we're like, okay, cool. This is exactly what's going on. And we'll kind of get change and then send back. And he's like, cool, I don't have to do surgery. I'll do some of these other like orthodontics and night guards to splint it now after you've done your work. And that's a pretty cool working relationship, especially when he has somebody who comes in who's like, well, I don't want to do surgery. He's like, cool, well then go to these guys, let them fix it, right? So sure, I told you I was riffing. I forgot what I was talking about. So we see this whole mechanism here. And I'll also start to ask some questions as well, especially in females about, not to ask those questions, but I'm going to try to feed in and find and pay attention to if they tell me that there's a history of sciatica, if there's a history of low back pain, if they're postpartum, did these issues start after their birth, right? We're going to start to get all these different pictures so we can start to formulate our mechanism in our mind. Now, when I view, and when all of us view TMJ disorder, or really just any challenge in the body at all, we want to start to assess is this like a top-down mechanism or a bottom-up mechanism? Okay, so let me go ahead and go through a little bit more about what I mean by that. Especially with TMJ, one of the things we want to rule in or out is the stability of the pelvis. Okay. Now, a really classical presentation of a patient, especially female, that I will see in my office is going to be somebody who has a pelvic instability that they either do or don't know about. Because of that pelvic stability, anytime that they're in gravity, their brain is going to freak the F out, right? Like, I can't get stability of my pelvis. And so what it's going to do, and I'm explaining this in like patient terms, okay? Or my version of patient terms. So I'm sure that you guys know the full neurological mechanism here. I'm not going into it, right? So what we know is that the brain can't get stability of the pelvis. So it can't move around like that all day. It's just too unstable. It's too stressful. There's too much unpredictability unknown. There's too much sympathetic stress that goes into not being able to hold myself upright against gravity. So the brain says, okay, cool. If I can't get stability of this pelvis, which is my foundation, I'm going to create as much rigidity and stability as I possibly can. So what it will do is it will essentially spasm, it will facilitate, it will cause restriction, okay, of everything from the sacrum and coccyx all the way up the spine into the upper neck and into the TMJ, where they finalize, put the cap on the stability by clenching their jaw. Now, if this is the case, if this is the mechanism, you can go and work that jaw, work that upper neck, work your cranial, work all day. They can go to the dentist for the night guards and everything else. If there's a bottom-up mechanism, until you stabilize that pelvis, they're not going to hold. So what does this look like in your office, okay? And if you want to really relate to somebody, if you have somebody who's coming in from another chiropractic office that they have great results with, and you're seeing an instability of the pelvis, which you should use we use an SOT style, we use a big SOT evaluation whenever we're doing TMJ care. Everything I learned, it comes from Dr. Marty Rosa when it comes to my SOT paradigm, okay? And amazing mentor, just brilliant mind in our profession. Super grateful we have him. Okay. So what's going to happen is that unless we address that stability of the pelvis, this mechanism is going to continue there. So you'll have this patient that comes into your office who will come in and they will say, oh my God, I love chiropractors. My chiropractor just like retired, right? I love chiropractors. I love them so much. It's the only way that I get through the week. I've had people come into my office and say, I just love it so much. I've gone to the chiropractor 2 to 3 times a week for the last 3 years. It is the only way I get through the week. And you're like, cool, I love that you love it. But like, if you're going 2 to 3 times a week for 2-3 years, like just maybe there's a chance that there was a component here that was missed. Okay, so this patient, what you'll find is that because all of that, like, you can feel and palpate and feel the restriction in their spine because it's all facilitated segments, right? Like the musculature is really tight around that. Like they have all the indicators of subluxation in those different areas. But it's not real. It's put there, right? The brain has put that there. So you got to go adjust that, or they go for a massage, or they do anything, and it feels effing awesome. Like we adjust that thoracic spine and that shit blows up, right? It's, oh my God, I was holding on to that. This is the greatest thing ever. The second they leave and go into gravity, it doesn't hold. It goes right back. So they end up using chiropractic care as a crutch because they can't get through the week without it because their adjustments never hold, right? And so you're able to tell that person, like, yeah, you've done 3 times a week for the last 2 to 3 years. We are going to stabilize this pelvis. What you're feeling there, right? Like, by the way, when that's getting adjusted, you can go into this mechanism or not, it only lasts for a period of time because your brain put it there. And now your brain is going to say the next day, wait, I facilitated that. I made that rigid. It's no longer rigid. I'm locking it down again stronger, right? And so if we don't stabilize that, that's going to continue to happen and happen and happen. And cool, we have lifetime patients, but we don't have lifetime results, right? And so we want to do a little bit better with that, a little bit better with the mechanism. So we can go through and explain that whole thing to the patient. But of course, that bottom-up stability is going to relate to the jaw. Side note on this, a lot of you guys might be thinking pelvic floor physical therapy for this, which is great, is a great idea, but there are specific ways that in chiropractic we can change our adjusting style. Most of everything I know with this, I know through SOT, I know there's different ways to approach this, that I would not adjust a patient with an unstable pelvis the same way that I would adjust somebody who does not have that. You need your own protocols. You need your own way to be able to address that. There's lots of different ways. Find them, learn them, go SOT, go do whatever else. Like find that because you're not going to side posture this patient into a stable pelvis. It's just not going to happen. Okay. So anyway, side note with the pelvic floor, we do have ways to address this. So a lot of times when I have a patient that has maybe done pelvic floor in the past, what I'll like to say to them is cool. Like one of the things that, and which is 100% true, it's not made up, it's not a gimmick. What we'll say is that, whenever we see issues like this, right? What'll happen is either you go to pelvic floor physical therapy, you get 90% of the way better and you come here for the remaining 10%, or you come here and you get 90% of the way better and then you add in pelvic floor physical therapy for the remaining 10%. Which one of those doesn't really matter. It's just these two things are needed to be able to get the best results. And this is how we foster an amazing collaborative relationship in our area, because I don't think that the only thing anybody ever has to do, again, to help all of their health issues for the rest of their life is chiropractic care. I understand there are other professions as well. I'm just going to super focus on doing the one thing that I know is going to be, that I am going to be best at, that's going to help with the best, which is chiropractic. Okay. By the way, questions and things you want to pay attention to if we're finding an unstable pelvis here, you're going to find a mom who needs to cross her knees when she sneezes. You're going to find somebody most likely who is, especially in women, was a distance athlete or a dancer. You're going to find a big hyperlordosis. You're going to find a crazy sacral base angle. You're going to see all these different indicators that just show that we're not supporting from the bottom up. And so if that's the case, we're going to address that first, right? And so what this mechanism is going to look like in a bottom up is going to be an overarching of the low back hyperlordosis, which is now going to lead to a really, really, really big anterior head posture. Okay. Now that anterior head posture is a big thing. As that head comes forward for TMJ, what's going to happen is the jaw is going to recess backwards. We're going to have a big amount of tension in the posterior cervical muscles, which is going to relate to neck pain, headaches, etc. And then, of course, because of the change in tension in the anterior part of the cervical spine, as well as other mechanisms too, we're going to be clenching that jaw again for stability, like I mentioned. Now, addressing that from the bottom up and addressing all of the compensatory components as well with the jaw is going to lead to a lifetime of results, not just physical symptom wise, but also autonomic nervous system also, because of how you're helping their brain and body reprocess itself in space. And most importantly, we're going to do that differently. It's going to feel safe. Cool. So that's a bottom up mechanism. It's not like that every single time though. The other is going to be our top down. And then there's this feedback loop that happens between the TMJ and the neck. In the upper cervical spine, there are 3 different pieces that I like to evaluate and look for and kind of look at this feedback loop in my mind when it comes to TMJ disorder, and especially how that relates to clenching and grinding and bruxism. Okay. Number 1, what that's going to be is that it's going to be the sympathetic overdrive. I have somebody who's in chronic sympathetic stress because of the trigeminal nucleus, because of the trigeminal nerve. There's going to be a huge impact of grinding, and it happens with an anxious response because of the way that feeds into that fight or flight response in the central nervous system. Okay. If you want to go deeper into that mechanism, ask people like Dr. John Chung that could talk me under the table with that mechanism. Okay. I'm just giving you the really, really big, easy 1,000-foot view of that. The next piece that we're, of course, going to be paying attention to is the actual physiology itself. The stability of the jaw is the airway, okay? And what we find a lot of the time is that in these different cases where the head comes forward, the patient, naturally, their jaw will drop back because of that posture. And as that jaw drops back and recedes, it can actually narrow the airway. And so that clenching and grinding is part of the body's actual mechanism to be able to pull that jaw up out of the way, which is super, super, super important, and be able to keep us oxygenated, not just during the day, but at night. Now, at night, what's going to happen is, of course, this patient is going to be somebody who snores, because as they lay back, as they get out of gravity, their tongue and their jaw are going to move back. They're not going to be able to appropriately rest their tongue on the roof of the mouth, which is going to relate to a number of different issues that I'm going to talk about in just a second. And now, because they can't do that, they're going to open their mouth and they're going to be snoring at night. Then they've been told, oh, you're snoring because you have sleep apnea, blah, 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 blah. Like, no, show me a patient who snores at night with TMJ disorder. I will show you a patient with a crazy anterior head posture. They might even have a good cervical curve, but their cervical curve only looks good because they have a super steep T1 angle. And what they're doing is, because their T1 angle is so steep, their head's so far forward, instead of what would naturally happen if their occipital base stayed in line with their upper cervical spine, they'd be looking at the floor, but they can't do that. So they're going to look up and they're going to keep their eyes on the horizon. So it's going to look like if you were to just say, oh, here's what a normal curve looks like. Here's what your curve looks like. it's going to kind of be masked and the curve is going to look better than it actually is. But that's just because they're essentially living their whole life with their neck in extension, right? Their neutral position is a super straight cervical curve, and they're essentially extending their head in order to be able to keep their eyes to the horizon, which makes their cervical spine the curve look better, even though we know that it's a mess. And if you're going to look at those flexion extension patterns, even though the curve might look okay on neutral, if you're not really trained to know what a curve should actually look like, measuring specific angles, when you look at the actual motion, flexion extension motion of the spine, you're just going to see that patient is like complete. There's no motion either direction. It is completely locked into that position because the upper cervical spine is in extension and the lower cervical spine is in flexion. Okay, and that's the mechanism that we'll see a lot of the time. So anyway, talking through this, what does this show up on your table, right? So we do our evaluation, we check our pelvis, let's say it's stable. So we'll go ahead and we'll do our TMJ evaluation. And first thing that we're going to feel here is as we're going through our evaluation, we're going to notice a number of different things that are really just putting us into like, oh my gosh, there is a global mechanism that's here. Okay. We're going to most likely feel really, really, really big spasms of the masseters, of the temporalis muscle, and we're going to actually feel oftentimes huge ridging of the temporal bone in itself. That ridging of the temporal bone because it's actually rotated. And that rotation of the temporal bone, remember, it's the T of the TMJ. It will literally draw up and out the condyle and will cause jaw deviation right from that. So that deviation is also going to relate to the recessed mandible as well. So they're going to look like they have a really weak chin. They might be, if they're a male, masking it with a beard. Okay. So just pay attention to that. Oftentimes when I see somebody in a beard, like the first time I ever took TRT, I'm sorry if you guys are big TRT people, I remember like looking at Dr. J Holder, and I feel like I couldn't pay attention at all because I was just picturing what he would look like without a beard. And I laughed because I do that all the time with my male patients with TMJ. And I'm like, oh, look at that recessed chin that you're hiding underneath that nice strong beard that you've got there. Okay, so we're going to see that mechanism as well. We're going to see a tongue that isn't able to appropriately rest on the roof of its mouth. And what that's going to show up as is a number of different things. So whenever I'm looking at palate distortions, there's two different pieces that I'm going to really pay attention to. Okay, number one is going to be the size and shape of the palate. Okay, and the normal mechanism that we are taught in the airway world is that if the tongue can't appropriately rest on the roof of the palate, it's going to grow up in a V. And that is why we look at things like tongue tie with palate development. That's why we're paying attention to the lower mandible and everything else like that. And I want you to know that is 100% accurate. If the tongue isn't going to appropriately rest on the roof of the mouth, that pressure on the roof of the mouth is not going to allow for the appropriate U shape to develop. It's going to be high, it's going to be vaulted, it's going to be a V shape that's very narrow. You're going to see changes in the teeth. The tongue is going to press forward instead of up. So you're going to see this inclination of the teeth going out. There's going to be all of these different mechanisms there that are very important. But it is incomplete, because if that was the entirety of the issue, what they need to do is go to OMT, they need to go to myofunctional therapy, and they need to see your dentist, and you can get the F out of here, right? There's nothing that you need to do. What I am going to pay attention to here, looking specifically at a few different places, especially the intermaxillary suture, basically the suture in between those two sides of the maxilla. Now, those are two bones that fuse together over time. And if I am seeing a subluxation pattern, especially with the sphenoid bone, what I'm going to notice is that there's going to be a massive amount, typically, of compression and ridging at the intermaxillary suture. Okay? What that's telling me is this isn't just like a tongue resting on the roof of the mouth issue. It's telling me that there's a subluxation that is restricted. The cranium was trying to grow outward, but it couldn't because it was stuck and restricted. And there are specific patterns that we talk about Dr. Marty talks about in his Pediatric certificate series. I don't know what other programs talk about this. I've taken cranial psychotherapy. I haven't heard them talk about this mechanism, but this is a very important mechanism. It's not going to be able to grow out because it's restricted at specific sutures, okay? I'm not going to go into the specifics because the only person I've ever heard talk about this specific thing is Dr. Marty, so we'll learn from him on this, okay? But what's going to happen now is if it can't go out, it's going to start to ridge up and basically buckle. Like the strain is going to cause the maxilla to essentially buckle. So when I'm seeing that ridging of the intermaxillary suture, I know that the sphenoid is going to be very, very restricted. Now, as the sphenoid moves during normal development and during every time we breathe in our CSF pumps, as the sphenoid moves into flexion, the maxilla should widen. So if I'm seeing that pattern, I'm expecting to find a sphenoid that's distorted. It's not moving to flexion or it's extension. It's probably has some lateral flexion or torsion restrictions. There's this whole big element that's happening there, and that palate gives us such a window into what the rest of the actual cranium is doing. Okay. Now we start to look at that. Well, the sphenoid is the cornerstone for the entire cranium. There's like 19 bones. It touches 17 of them directly and the other 2 indirectly. Okay. There's cranial nerves that are influenced by the sphenoid. The pituitary gland sits in there. The sella turcica, right? We have dural attachment all the way around it. It is massively important. And that distortion pattern is going to be really, really, really challenging for that nervous system, right? Which is going to lead further into that sympathetic overdrive. Now, on top of that, if there's ridging there, what that is also telling me in that further indication that that patient is clenching. Okay, whenever I'm seeing ridging, I know that there's clenching and bruxism. And then once I see ridging of the intermaxillary suture, I'm going to come up as well and check things like the sagittal suture, because that patient, in order to be able to get stability, try to get motion, they're going to be clenching and grinding and trying to get some input into their brain. And so they're going to do so for so long that there's actually going to be so much tension on the falx that we'll literally see ridging and gapping of the sagittal suture. They never feel that, but you palpate it and they're like, what the F is that? And it's like, yeah, this is another piece of the puzzle. Okay. So we have all of these different pieces that lead into these cases. We have this sympathetic overdrive. We have this stability of the pelvis and stability of the TMJ. We have this airway dysfunction, and all these different things are happening simultaneously. What's happened in the past is this patient has been everywhere. This guy, this guy, this guy, this guy, this guy, this guy, this guy. And all of these have maybe looked at each of these in a small window microcosm. No one has ever put these together. Now, we as chiropractors, one of my favorite quotes from Dr. Amy Spolster is, we don't need to do more, but we need to know more. When you can take a step back and not just be, even though we talk nervous system, which is the piece that everything goes together, if we can take a step back and not just be, pretend that we're the only holistic person that looks at everything because we look at the nervous system, but actually look outside of our own little scope and say, wow, these are all of the little pieces together. We can address the pieces through our framework that we need to address, while also letting them know that these are the other pieces of the puzzle that are going on. We can adjust in such a way that not only is going to influence the cranium, but it's going to influence the airway. And we can have specific outcome measures to say, hey, we did a really good job here. This is the improvement that we saw. This is the improvement that's still remaining. So this is the provider that I want you to work with, because that also impacts your body. Right? An airway dysfunction is going to lead to deoxygenation at night. There's research that shows that you have patients that walk around at a 98% O2 saturation during the day, and at night, even though they're not feeling any symptoms, they're dropping down into the 80s because of their airway dysfunction, right? And what's going to happen is that patient is never going to get a full night's rest. This is the child that at 6, 7 years old, they behave all the time like they're a toddler who missed their nap, right? Because they're not having a good airway at night. They're not having good quality of sleep. And if you've never been overtired, you know the amount of chronic sympathetic stress that goes into this. So we're seeing this full mechanism in all of these different places. And as chiropractors, it's our job to be able to look at all of this, to be able to care plan around it, to be able to have specific outcome measures to know, hey, this isn't just you came in for this thing, but these are all of the other pieces that are connected to it, because we can see the body. So we can start to plan around those things, let the patient know to look out for those things, and start to understand how their body truly is connected, not in some woo thing like, oh, my toes are connected to my jaw. Like, no, this is the actual mechanism for how this is connected, and we can become their lifetime care provider, because we truly are not primary care, but we are a quarterback. Right? They know that we are the person who understands how their body actually works. We know how it is that we can improve its adaptability within our own framework, and we can help them find the different pieces of the puzzle to be able to make sure that they are going to live their life at 100%. That's the thing that I want all of you guys to be able to do. That's the reason I love these mechanisms. That's the reason I love this cranial work, because I'll have a patient that comes in and they haven't told me about anything else. The only thing they're here for is their neck or their jaw or their this or their that. And we start to actually feel this ridging of the squamosal suture. We start to see this cranial and palate and TMJ things. And we start to ask these questions like, oh my gosh, like how bad are you right now? It's like, it's the fall. Your sinus is pretty bad right now? Yeah. Yeah. Oof. Like, you ever kind of notice you're chewing more on one side versus the other? Yeah. sometimes we'll see this issue showing up, and I'm not saying that, we always talk this one lightly, right? I'm not saying this is the case, but like, especially women who have multiple children like you will find with this instability here that they'll have to do things like cross their legs when they pee, or they feel like it's really hard to stay still, they're swaying side to side, or they're just overall feeling like they're not kind of themselves when it comes to like their pelvic floor. And I'm like, oh my God, yeah, I didn't know it was a thing. I just thought that it was normal for me to pee my pants whenever I laughed. And it's like, yeah, okay, maybe there's something that we can do about this. So anyway, I have no idea what I said over the last little bit. That was a lot of fun. You probably didn't speed up that this podcast episode. You probably slowed it down, and that's totally cool. I hope you got some value out of this. I hope that I didn't just ramble incoherently for the last little bit of time, and I hope that you can start to go into your office and look at some of these challenges through a different lens, and maybe even you're inspired to say, I understood a portion of what you just said, but oh my God, I want to understand all of it, and I need to see things through your lens. If that's the case, make sure, A, you are on the Cranial Doc email list at thecranialdoc.com, and shoot me an email and let me know. Right? Get on that email list. It'll email you from me. Let me know that you want to dive deeper into this mechanism. Let me know that you want to learn more. I'll probably ask you questions like, what is it that you've done so far? What does you look to gain? And I'll point you in the right direction, either to a program that exists, or I can be convinced to write one myself. I'm in the middle of doing that for some things right now. Anyway, I hope you had a beautiful day and a great time on this episode. Hope you go out into the world and slay some subluxations, get more people face down for longer with less work. All right? Get out there. Thank you for listening to another episode of the Cranial Doc podcast. I hope you got a ton of value out of today's episode. And if you did, it would mean the world to me if you jumped over to iTunes or your favorite podcast player of choice and subscribed, rated, reviewed, and shared this episode with a friend that you know could benefit. We have a ton of this information and more in our free email series at thecranialdoc.com. So go ahead and jump on there, subscribe, and get me raw, unfiltered in your inbox every week, changing your practice. Can't wait to see you for the next episode.